Hello, I'm Dr. O.P. Singh. I'm a neurosurgeon in Prayagraj, UP, India. And today I'm telling about UBE discectomy, its basics, and I will try to explain in detail about how to do UBE lumbar discectomy. And first we start with anatomy for midline approach and for para-UBE, that is from the side of the vertebral column. So let us come to midline approach. There are certain things which have to be kept in mind about the height gap between disc and the internal area, prelaminar space, multiple fascicles and interfascicular space, arteries above lamina like superior articular artery, inferior articular artery, interarticular artery, and segmental artery. Then shape of the lamina and spinous process. Then one very important structure is that is ligamentum flavum. Ligamentum flavum has two layers, superficial and deep layer, and there is a union midline cleft and its fiber direction. There are attachments, inferior attachment, lateral attachment, superior attachment. Then there is junctional area, junction of lower lamina and medial margin of the SAP. Then epidural venous plexus and all loose eroded tissues. So this is the in toto of figure of ligamentum flavum, and this is the midline cleft. This is superficial layer, this is deeper layer, and this is upper attachment. It is under surface of the upper lamina, and this is beveled attachment, one above the lower lamina and other anterior to lower lamina. This is whole ligamentum flavum. The upper corner point toward the exiting root, while the lower corner point toward the traversing root. And at the lower lamina, the attachment is at the margin of the lamina, below and above, while on the superior side is it on the undersurface of the lamina. Then in the foramen also, this ligament reaches over the root on the pedicle wall and border the foramen. This is figure of into toe butterfly removal of the ligamentum flavum. Then there are compressing factors from all around, anterior, posterior, lateral. It may be hypertrophic ligament, hypertrophic facet, facet joint cyst, overhang of medial margin of SAP, then bulging disc, and all you already know. Then coming to the philosophy of UB, we use, there is no hollow viscera like abdominal cavity, urology, and in spine there is a potential space that is known as prelaminar space and one muscle, multifidus. It has interfascicular space. This interfascicular space to be joined, this interfascicular space and this prelaminar space through the power of semitubular retractor and hydrostatic pressure of water. That is very important to enlarge and make a initial working space here. And after we get some space to work our instruments and scope, then we drill this bone, and then the space is wider, and that is known as actual working space. This is facet, and these are the multifidus. And through this physical, we reach there. You can see in MRI also, there is multiple interfascicular spaces. 3 or 4 tips of this multifaceted muscle arises from the spinous process and then attached to a single mammillary process of SAP. So this is how we enlarge this space. Then facet anatomy, facet, the L shape of SAP, and there is joint space. Then this bulbous part of IAP, inferior articular process. This is IAP, SAP. This is like C. So sometimes this overhangs, sometimes this facet joint cyst enlarges and compresses the traversing root, and ligamentum flavum buckles, hypertrophies, and this causes stenosis. Then there is anatomy about paravertebral area, that para-UBE. This is the gambit triangle, and this is the SAP. Margins are attached with the ligamentum flavum, and this is eating root. This thing here somewhere is traversing root, and this is midline cleft. This is cut lamina. So our working area is this. Then thoracolumbar fascia and other muscles, back muscles, outer layer iliocostalis longissimus, middle layer semispinalis multifidus, and inner layer rotators interspinalis and intertransversal muscles. You all know. I'm here to tell about the fascia and how it is important, because the fascia, thoracolumbar fascia, is covering this muscle group. One muscle group is here, other muscle group is here, which is iliopsoas, and it makes the anterior and posterior compartment, apexial and hypaxial muscles. This is apexial muscles, and here is hypaxial muscles. So these two groups of muscles are separated with fascia, and there is a lift and junctional area. This is quadratus lumborum, and this area is psoas, and this is the fascia, thoracolumbar fascia, covering multifidus, longissimus, iliolumbar, and this space is bounded by fascia. And once you fill this space with uh, irrigation fluid, 3% irrigation saline, this doesn't leak into the abdominal cavity because of this tough fascia. If you injure this fascia or you go beyond transverse process, then there are chances of fluid accumulation in retroperitoneum. So be careful. Other thing is this fascia is important because this is attached to the tip of spinous process. So it is very tough structure and it hampers your movement of instruments, as well as the egress of fluid is hampered by this fascia because it is very tough structure. So you have to divide this fascia as explained in later slides. This is hypaxial muscles, apexial muscles. This is paravertebral muscles, and this abdominal muscle, intermuscular septum, and the quadratus lumborum muscle is there. Divides the fascia into two layers, anterior and posterior. Some people divide it one posterior, then middle, then anterior. So importance of fascia. This is the thoracolumbar fascia, and very tough structure. The fluid medium, we use 3%, 3 liters saline, 3-liter bag of saline over the surgeon side. Usually height is 50-70 centimeter height from patient bag to saline bag, and it is roughly divided by 1.36, that is 30 to 50 millimeter of mercury pressure. It is sufficient to stop venous oozing, bone oozing, and bleeding, but not arterial bleeding. The complications of fluid, you all know, it may cause headache, nuchal pain, intracranial hemorrhage, seizure, delayed awakening. Blindness may be possible, but hypothermia is common for initial cases, and sometimes massive abdominal fluid collection if you injure the fascia. This is our setup, 3 liter saline. This is the height. This is input and output. The more important thing is output channel should be unobstructed. If it is obstructed, the fluid will accumulate here, blood will be not washed out, and your field will be not good for operation, and you may create complications. So it is very important. The egress of fluid, that is the output fluid, is where it is your instrument port. This instrument port is wider than the scope port, and it is usually 7 to 8 millimeter, or sometimes we need 1 centimeter also. So it should be unobstructed. Semitubular retractor helps. This is all video monitor and camera, RF light, so drill put all set up. Anesthesia, GA epidural, local plus sedation, sometimes in highly friable patient, but usually GA is preferred. Position is prone, abdomen free, Wilson frame is good, but if you can use flat rolling pads also, but abdomen must be free so that it may not cause pressure on the inferior vena cava and cause venous oozing. With draping is done with adhesive sealings of large area about 10 centimeter from midline to avoid hypothermia, and we do double sealing of the operative area. Craniotomy drape neurosurgeons use is good. Location of surgical system and irrigation lines should be on the left side, and the endoscope related lines like camera and irrigation lines drill it RF on the right side. Instruments, most of the general spinal instruments can be used, but few special instruments like this T-shaped handle. This T-shaped handle is for muscle separation from the lamina and opening of the interfascicular fascicle space. Different types of UBE specific instruments. Serial dilator. This is semitubular retractor, working teeth, semitubular retractor, dissector, RF probe, different types of RF probe, and scope is sometimes used. Very useful, but not usually routinely used, but sometimes we can use for contralateral barking. Serial dilator. This is the position, Wilson frame. This is patient lying, abdomen is free, and yeah, this abdomen is free, and wide preparation is done. Then double draping. First draping, we apply tincture also so that fluid does not soil the patient body and cause hypothermia. It has to be done. And the second layer, panel drape, is applied over this adhesive draping. Then we proceed to marking. This is marking of the midline in AP view, upper end plate, lower end plate, then pedicle, medial pedicle margin, the upper margin of the pedicle, the lower margin of upper pedicle, and this is Stanlamana junction. To triangulation is basically your instrument in front of your scope. Instrument in front of your scope is triangulation, and this angle should be around 30 to 35-degree angle inside the canal, not outside the canal. This is how we mark the medial side.
Yes.
And if it, we confirm with needle what our trajectory should be at the spinal junction.
Yes.
Then how we proceed for incision. So this is the instrument port side, and it should be in the line of discectomy. If you are planning for discectomy, it should be in the line of disc, and we it is wider. And first we make instrument port. This is incision, and after incising, we cut the fascia. As I explained in earlier slide, fascia division is very important to make your instrument really move, and so your output fluid, irrigation fluid egress become easy. Then we put the dilator, serial dilator, and try to separate muscle from the lamina. And our movement is medial lateral and craniocaudal. So you can feel it. While doing this, you can feel the lamina, you can feel the uh, facet joint. Never do if you don't feel bone. Bone is your friend. So always be careful that you are on the bone. This is how we divide the fascia after the spinous process. And after this, we put all the dilators. Then we proceed for scope port. This is the dilator, and these dilators are kept inside for hemostasis. And once you apply all the dilators, then it becomes very easy for triangulation because you hit on the dilator with the blade and put your scope teeth like this, leave it in there, and then this this is making of the scope port, and you incise. You can feel this movement of this uh, dilator setup, and directly put your teeth on the dilator. The triangulation is done. You can confirm with X-ray. This is on the back side. You can see this X-ray, and you can jointly move this combination as per your comfort and create a space below the muscle of
This is
lamina.
triangulation. Yes.
This is confirmation. This is the dilator teeth, and this is scope teeth. So the triangulation is done. angle inside it will be 30 to 35 degrees. ठीक है? Then coming to the floor area, floor anatomy of multiple triangle, we see for this C junction, our working starts from here, and this is known as spinal laminar junction. This is spinous process, and this is lamina, and this is IAP. This is lower lamina. This is the area of ligamentum flavum. This is midline. So we work in 3 arcs, 4 arcs. First arc is this lamina line. Second is below the spinous process, the base and the part of spinous process is drilled. Then we work on opposite lamina, and then we work on this lower lamina. We separate this all side of ligamentum flavum. We coagulate and we make this anatomy clear, and you can see this how we coagulate. And this C is would be in your mind clearly. This is a IAP, and this is clearing of the soft tissue from the internal lamina area downward. Here somewhere is lower lamina. This is lamina. Okay, you can see. Okay. We start drilling from here and come along the first curve, that is lamina curve, up to IAP. Starting of drilling, there is spinal lamina junction and the spinal process. This is spinal process. This is junction, and we start here. Yeah, this is the drilling of this part to create a wide working area also. That is actual working area. Once bone is drilled, you get sufficient space, and fluid chamber. Actually, where you are working, this fluid chamber is enlarged. Less it is less obstructed by muscles and soft tissue, and your working area becomes clear. This is how we enlarge drilling and this. Then we remove, when the cut is thin, we remove with garrison. is how we do. In another case, dealing on the sinus process, you see the ligamentum flavum here, and this is the midline cleft. We reach up to the upper attachment of ligamentum flavum under the upper lamina. Now we remove this kerrison like this. Enable all the anterior cortex to clear the ligament anatomy. Then once we explore this area, this IAP area partial, and then proceed to this area. This is the opposite side of lamina, and this is the IAP, this is the SAP, and this is the angle. Clear all the area of ligamentum flavum is attached to the medial margin of SAP. When I start working here at the junctional area, this is the SAP medial margin from where the ligamentum flavum is attached. And here the two layers of ligamentum flavum are there at the angle of that is junction between SAP and lower lamina. Here the outer layer, superficial layer is more loose and separate from this corner area. This is SAP, IAP, margin of lower lamina, upper margin, and this deeper layer, this is superficial layer. And here the root exists. It's a traversing root. The traversing root, sometimes this is there, so you can approach from here. You could separate with curate also this area, superficial layer is separated, and you could separate. There you can, this is how the SAP looks. This is another case for incision surgery, and that's it. We remove the SAP, but this is the white is shiny, signable surface of SAP is a landmark for your uh, orientation also, and where you are. Okay. So once we free the ligament from upper attachment, lateral attachment, and lower attachment, then we gradually dissect it, and the whole ligament is removed. And this is how the theca looks. Okay. So recap, this is how we drill, this is how we cut, and how we separate ligament, and all in one lower junction area working here, and discectomy. Thank you. Then we proceed. This is panlama junction. The slide panlama junction drilling. All I told you. With one other case where end plate along with disc had herniated, and this is how we removed it. This is bony and disc fragment. Then after disc space is cauterized, it is known as annuloplasty. So this is the final bony 3D of a case, which is showing how much bone is removed. This is the part of lamina is removed. This is part of SAP is removed, and part of lower lamina, part of this spinal process. The attachment of multifidus is not disturbed, vascularity is not disturbed, neurological supply is not disturbed. Then coming to the para UV from the side, it is usually valuable in many cases of foraminal disc or redo cases. We land on isthmus, sometimes we land on junction of TP and isthmus, and this is the whole anatomy. Isthmus, IAP, SAP, and you can simulate with this pillar, pedicle, and this is facet joint, IAP interpars, then IAP, SAP junction. For this prominent disc or extra prominent disc, you can use this approach. Sometimes because of collapse of the disc and facet joint subluxation, there is telescoping of the facet joint, and SAP hits the root against the pedicle. So sometimes this globular or larger upper part is obstructed by this movement and it pinches the nerve. So this can be handled by doing partial removal of the SAP and widening the ligament, widening the foramen. Sometimes you need to do some part of pediculotomy also. So this is all possible with para-UV. This is anatomy of the foramen. This is root, and most importantly, foraminal ligament is ligamentum flavum, reaching up to the foramen. Now we sometimes this the distance between the pedicle reduces to this, and this vertical orientation of root becomes horizontal. So you need to do some part of pedicle resection like this to make it more vertical than more horizontal. This is how we start. 1 centimeter from the mid of the transfer process here, 1 centimeter from the mid of transfer process at the lower side, and this is working portal, this is scopic portal. We land on this area landing point, and this is our working area. We start drilling at transfer process and parse junction and proceed like this. Okay, thank you so much for your kind attention.